Welcome everybody on this cold January morning. It's an exciting GI morning today. I get to introduce Dr. Tad Dryden, Professor of Medicine, who is really our gadget guy, works a lot with the Speed School, now is working with Dr. Ken Palmer for development of a novel device to put anti-COVID prevention medicines in the nasal passageways. So Tad is somebody that I don't think ever sleeps, and he never stops moving. So with all of his energy, he's a family man, and he has raised 3 daughters who are all involved in professional type careers. One is a lawyer, one is a Navy physician, and one is training to be a Navy helicopter pilot. So I know that is his pride and joy. So with that, now his face is sufficiently red. Tad, I will let you introduce our guest speaker for today.
Thank you very much, Dr. Kruger, and welcome to Medicine Grand Rounds at the University of Louisville for Dr. Uni Wong. And Dr. Wong comes to us from the University of Maryland, and she has, in her academic career, has really accomplished a lot. So she originally started out at the University of California, Davis, and went to medical school at the University of Vermont College of Medicine. She completed her training in internal medicine residency at the University of Maryland Medical Center, and then followed that up with a fellowship in gastroenterology and hepatology at the University of Maryland Medical Center. Since then, she has been definitely working on bringing the good word for inflammatory bowel disease treatment to the residents around her academic center. She is very involved in working with the medical students and other training programs, and over time has become an assistant professor of medicine now, who is also the Associate Program Director of the Advanced IBD Fellowship, and also is the Gastroenterology Training Director for the Physician Assistant Program there. As you can see from her title slide, she's also the IBD Clinical Director at the VA Maryland Healthcare System, and I'm very excited about dragging her into some trials that we'd eventually like to be able to do with some of the other VAs. Get ready to hear from me down the road. But without further ado, let's go ahead and hear what you had to say. The title is Recent Advances and Developments in the Management of IBD. So Dr. Wong, take it away.
Thank you for the kind introduction and for the invitation. So at the end of the talk today, I hope that you will be able to describe the clinical presentation and complications of Crohn's disease and ulcerative colitis, be able to identify predictors of a severe disease course in our patients with IBD, and define new treatment options that are available for our patients. So I'm going to start by doing a quick overview of inflammatory bowel disease. Crohn's disease and ulcerative colitis have their highest prevalence in Western industrialized countries of Europe and North America. We have been seeing intermediate prevalence in developing countries since World War II, including Japan, Hong Kong, Korea, South Africa, and Israel. As new areas are assuming Western cultural practices, we're seeing increased prevalence of ulcerative colitis as well as Crohn's disease. The influence of environmental factor is very clear, as we see when immigrants, such as Japanese immigrant, when they move to Vancouver, the children are having higher prevalence of inflammatory bowel disease than the first generation immigrant. What about age and sex distribution? In general, the peak incidence occur in late adolescence and early adulthood. So we see a lot of young folks coming in with symptoms, first diagnosis of IBD, very debilitating, as you can imagine. This is a time when they are going through high school, college, and early working age, dating age, childbearing age. So these diseases can have a huge impact on their quality of life and psychological health. In general, the frequency of IBD is similar in males and females, with a very slight female predominance shown in some studies. And many of studies have demonstrated that when inflammatory bowel disease is diagnosed at a younger age, we tend to see more distribution in proximal GI tract, such as in Crohn's disease, we would see oral, gastric, esophageal, duodenal. In Crohn's disease diagnosed at a later age, we see more colonic involvement. And as you can see on this diagram, we do get patients in the very, very early pediatric age in both Crohn's and UC. And we do sometimes see first-time diagnosis after age 60 even. Well, what is the pathogenesis of inflammatory bowel disease? I think it's quite clear that there is no one pathway that leads to inflammatory bowel disease in our patients. We know that there is some genetic susceptibility compounded with luminal antigen and some environmental trigger. All three play an important role in development of IBD. In animal models, no one single factor was sufficient to induce this chronic relapsing immune-mediated intestinal inflammation. And therefore, I think in the future, it's clear that a multimodality approach will be the way to cure inflammatory bowel disease. But we are very far from that point. Inflammatory bowel disease can often be underdiagnosed initially or misdiagnosed. I always emphasize to the trainees that while abdominal pain and diarrhea could be irritable bowel syndrome or due to other etiologies, there are some red flags we cannot ignore. Red flags that should prompt you to think about inflammatory bowel disease include anemia, thrombocytosis indicating inflammation, increase in SED rate, decrease in albumin, indicating their nutritional status is affected. Similarly, if someone comes in with weight loss, fever, perianal disease, such as perianal fistula, perianal abscess, if they're reporting bloody stool, if they're reporting tenesmus, the sensation of having to go but nothing's coming out, or if they're presenting with fecal leukocyte, occult blood, positivity, those are patients that you want to investigate further with endoscopy, colonoscopy. With ulcerative colitis, we tend to see rectal involvement and disease progress proximally to sigmoid colon, descending, etc. We see a continuous distribution of the mucosal inflammation. Oftentimes, the inflammation is only at the mucosal level, in contrast to Crohn's disease, which we'll talk about next. And of course, ulcerative colitis is distinguished from Crohn's disease in that it only affects the colon. So what are some of the features of Crohn's disease? So if someone has perianal disease, at the very bottom here, they present with an opening, a fistula, an abscess. By definition, this is characteristic. They often will have rectal sparing, but we'll talk about later how in some patients with really progressive disease, they can still have rectal involvement. Majority of patients will present with no bleeding. So many of our patients will not have just gross bleeding. 20 to 30% will just have diarrhea, for example. Small bowel involvement is a characteristic of Crohn's disease. You can have skip lesions. The endoscopic features are demonstrated here, where you have these deep, deep ulcerations, and you may have luminal narrowing, defined as a stricture. Granuloma is a pathognomonic for Crohn's disease, but just because you don't see it on your biopsies, that does not rule out Crohn's disease. You can have just very focal lesion, again, skip lesions, and you can have fistulization as well if the ulcers get deep enough. But again, Crohn's is a transmural disease, unlike ulcerative colitis, where it's mostly mucosal involvement. What about the anatomic distribution of Crohn's disease? Majority of the time, there's some terminal ileal involvement. Small bowel involvement alone accounts for about 33% of our patients. Ileocolonic involvement of ileum plus some part of the colon takes up about 45%. And 20% of our patients with Crohn's disease will just have colonic involvement, which, as you can see, can be difficult to distinguish from ulcerative colitis, especially if the colonic involvement shows continuous distribution and with rectal involvement. Sometimes we label these patients as indeterminate colitis when we're not quite sure what to call it. And it only really has an implication when we're thinking about surgery down the line. If someone's having a colon out, we want to make sure we determine whether they truly had just Crohn's colitis or ulcerative colitis to determine if they would be a candidate for a reconstruction ileal pouch anal anastomosis, otherwise known as a J pouch. I think it's very commonly known that inflammatory bowel disease patients have extraintestinal manifestations, including aphthous stomatitis, episcleritis, uveitis. They can have arthritis. They can have vascular complication, specifically DVT and PE. It's very important that when a hospitalized sick patient with inflammatory bowel disease, even if they're having rectal bleeding, that they get on DVT prophylaxis in their hospital, because the rates of thrombosis is much higher in this group. Many of our younger folks will say, I'm young, I walk around, but the inflammatory burden is just so high when they are sick that we see vascular complications. Of course, on skin, we can see erythema nodosum, pyoderma gangrenosum. Now, let's switch gear a little bit to talk about how we can risk stratify our patients with inflammatory bowel disease to determine which set of patients will have a more disabling disease course and which ones are at risk for surgery. So the American Gastroenterological Association has put forth a set of pathways to help us determine and risk stratify which patients will have a more disabling course. The ones that you think about for Crohn's disease are the ones who have more anatomical involvement. The ones with deeper ulcers, these are often the ones that will present with intra-abdominal fistula, intra-abdominal abscesses. Folks that were diagnosed younger than age 30, those who have perianal disease and or severe rectal involvement. Of course, if someone has had surgery already for Crohn's disease, those are the folks you want to pay closer attention to, because as history has shown us, they're going to have another surgery in the upcoming years unless if you do an intervention to prevent the recurrence of their disease. Those with more complicated disease behavior needing hospitalization, steroid need, those are the patients that you want to be careful about. And the AGA also set forth some risk stratification strategy for UC patients. Extensive colitis, meaning colitis that crosses the splenic flexure. Those with deep ulcers, those that are diagnosed at a younger age, with higher CRP, higher ESR, steroid requiring, history of hospitalization, patients with opportunistic infection. So it's always misconstrued in that, oh, a UC patient is just having a bad time because they got C. diff. But UC patients who get secondary opportunistic infection often have an underlying uncontrolled UC course, predisposing their pretty sick colon to these opportunistic organisms. So while it's true that we got to take care of the C. diff alongside with the severe or moderate UC, it's important to keep in mind anytime a UC patient has repeated courses of opportunistic infection, it's a sign that their underlying UC is not well controlled. So over the past decades, how have we changed our approaches to treatment in these patients? Historically, in the pre-biologic era, the therapies that we have were not disease modifying. They were mainly controlling symptoms. Corticosteroid had to be used often to manage symptoms, but they were not getting to the mucosal healing level of disease modifying. And traditionally, the thought was, I give a patient a medication, they feel better, my job is done. So it was a symptom-based treatment. That is no longer the case. We have learned that if we don't document mucosal healing, whenever we institute a therapy, where our job is not done. Patients may feel better, but if they don't look as good on the inside, we got to do something different with our treatment, whether that's dose escalation or changing therapy altogether. So oftentimes, I emphasize to the patient, we need to do another colonoscopy or a capsule endoscopy, because I need to show you that you look just as good as you feel on the outside. And traditionally, we were using a step-up therapy model. We tried, the 5-ASA, and if they don't do well, then we move up to the azathioprine, and if they don't do well, then we go up to the biologic. Over the past 10 years, we have learned that if we don't start with the most effective therapy, we are delaying care and allowing for disease progression. Thankfully, we have also demonstrated over the past decades that these biologic therapies that are highly effective are also highly safe. So we have changed the mindset in this field that it's okay to start with the most effective therapy and not delay care. Going back to why we have to document mucosal healing, it's very clear that patients' symptoms don't often correlate with inflammation in Crohn's disease. This was a study published in 1990 where they had over 140 patients with active colonic or ileocolonic Crohn's disease. They collected clinical, biologic, and endoscopic data. They put these patients on corticosteroid at that time for up to 7 weeks. And then they did another set of assessment looking at their clinical symptoms, their labs, and their endoscopy. And what they found was there was complete discorrelation between symptoms and severity of ulceration, highlighting the fact that even if the patients tell me they feel well, I still want to document that it looks good on the inside. So what do we aim to do in 2022 in IBD care? We want to induce clinical remission. We want the patients to feel good with no symptoms, continue to go about their day, whether it's working, going to college, going out on dates, getting married, having kids. We want them to avoid short and long-term treatment toxicity. And nowadays, the biggest one is avoiding steroid as much as possible, because we know that has the most toxicity of all the treatment we have. Enhancing their quality of life. Again, maintaining steroid-free remission, monitoring their disease periodically, even when they get into remission. Some of us will proactively check their drug level to see if their drugs need to be adjusted. Some of us will periodically check fecal calprotectin to ensure that we use some of these non-invasive markers to continue to show that they are still in remission. And again, we want to induce quote unquote deep remission. I think this was a term coined by Ray Cross and some of the other thought leaders, that we want to see biologic remission, but also mucosal healing. We want to prevent complications, prevent hospitalizations and surgery. So the STRI initiative was developed to emphasize treat to target model. When we see a patient with active IBD, we determine their therapy based on the risk of the therapy and their personal risk of complications. We look for symptomatic response, and we look for normalizations of blood markers. We look for normalization of fecal calprotectin, so fecal inflammatory marker. And in our young pediatric patients, we look for normal growth, as inflammatory burden can really stun their growth curve. We also then look for endoscopic healing, normalization of their quality of life, absence of disability. I think in the future, for ulcerative colitis, we are going to see if we would strive for not only endoscopic healing, are we going to look for histologic healing under the microscope? And that's still to be determined, because we don't want perfect to be the enemy of good. So CRP is a marker we use quite often in inflammatory bowel disease patients. This was a study, a retrospective analysis of clinical and endoscopic outcomes, looking at serial CRP measurements in over 700 Crohn's patients who were receiving infliximab. And it was clear that CRP measurements were associated with healing, mucosal healing, and it was also a good marker to help show that there's some inflammation going on when patients flare. So when there's any clinical relapse, in my office, we would definitely check a CRP, because if a patient's CRP had normalized previously and they're coming in with new symptoms, this is the first thing we would see show up before we schedule that patient for a potential colonoscopy again. Fecal calprotectin is another marker. It's a little bit more cumbersome for our patients because they have to collect stool sample for the lab, but they do it, especially if they are having a lot of diarrhea, easy enough to collect a sample. But it's also a very good marker that we can use. This was a study looking at correlation of fecal calprotectin. They also looked at CRP, fecal leukocyte, and the Crohn's disease activity index symptom score, and along with endoscopic scores. And what they saw was, of all those non-invasive markers, fecal calprotectin did the best job at picking up mucosal healing, and it was clear that this was the only marker able to discriminate inactive from mildly active endoscopic scores here. So during the pandemic, when we were not allowed to do colonoscopies, fecal calprotectin and CRP were highly utilized when patients presented with symptoms. So treating to target definitely has been shown to a superior outcome in our Crohn's patients. The CALM study was an open-label, randomized control phase 3 study that occurred in 74 hospitals in 22 countries, and including some outpatient centers in the study. What they had were patients that had active Crohn's disease based on endoscopy and symptom. They had one group, the clinical management group was standard of care, and then the treat to target group were patients who not only reported symptoms, but actually also had fecal calprotectin, CRP cutoff that they used. So if a patient had fecal calprotectin greater than 250, CRP greater than 5, and symptom score of greater than 150, or if they also used prednisone in the last week, these were the patients that had their treatment altered, whether it was to bring the adalimumab dose higher or adding a second agent. So by treating to target, they were able to show that the primary endpoint here demonstrated by the CDEIS score less than 4 with no evidence of deep ulceration. So the outcome was definitely better when we altered the treatment based on these biomarkers like fecal calprotectin and CRP. And secondary endpoints looking for deep remission, no steroid, CDAI less than 150, no fistula, no deep ulcer, that was also demonstrated to be higher in the treat to target group. And all this is telling us is, you know, patients reported symptoms and their reported use of corticosteroid is not enough. We gotta look for other markers and react to those markers if they come back high. Now, this was a study looking at whether adjusting the dose matters. And so it was clear that, so in this group, increasing, you have the anti-TNF change and then anti-TNF increase, the dose was increased. So if you have a patient that you're suspecting they're having a flare, you check their drug level, and what is recommended is if you see anti-drug antibody, and if you change their dose, if you increase their dose, it's not going to help because of the fact that the presence of these antibodies are chewing up the drug, and you're better off by changing their class to a whole new class of agent or to another molecule. The anti-TNF antibodies do not cross-react, so if you have a patient who has infliximab, anti-drug antibody, and you want to switch them to adalimumab, which is another anti-TNF, it would be fine to do so. However, if you have a patient who has who's coming in with a flare, you do your biomarkers, you document they're truly having disease, active disease, not irritable bowel syndrome overlap, and you find out that their drug level is lower than therapeutic range, we'll talk about later, by increasing their drug, you're able to get them back into remission. So the AGA clinical pathway for Crohn's disease is demonstrated here. If a patient is not responding to the biologic you're giving them, it goes back to what we talked about, checking their drug level. If they don't have enough drug in their system, you increase their dose. If they do have enough drug in their system, or if they, my apologies, if they do have high antibody level but low drug in their system, it's a good idea to switch them to another agent. And if you do see a therapeutic drug level with low anti-drug antibody, that tells us that that mechanism of action may not be the right mechanism of action for that patient. So you want to make sure you confirm that there is actual disease with colonoscopy, capsule endoscopy, if you can't reach certain areas of the small bowel. And if you confirm that there is inflammation, they've been getting the right amount of drug, but they're still not better, clearly, then you switch them to a whole new mechanism of action. Now, if there's no inflammation and they are getting the right amount of drug, you want to continue the drug at this current dose because they have mucosal healing, they have documented mucosal healing, and you want to look for other causes for their symptoms. So it's also very clear that drug levels matter. In GI, we are really all about drug levels. In this retrospective cross-sectional study with over 140 patients, they looked at the drug levels and documentation of mucosal healing, the percentage of mucosal healing rates. And it's clear the higher drug level, the more mucosal healing you see. And we have established that for infliximab, we strive to get the drug level at least 5, and for adalimumab, at least 7. And so in clinical practice, checking drug level helps guide therapy. And this is just some of the suggested trough target that we aim for with infliximab, adalimumab, certolizumab, vedolizumab, and ustekinumab, one of our newer agents. Definitely need more time and data to help us establish what the minimum trough level we should target for. So how do we manage complicated luminal Crohn's disease? In Crohn's disease, it's important to note that patients can develop strictures, they can develop fistula, they can develop abscess. A common misperceptions in inflammatory bowel disease is that if a gastroenterologist refer a patient to a surgeon, they have failed. But the truth is, many of these Crohn's patients do not get diagnosed until disease has been going on for years, if not a whole decade. Remember back when we were on that slide talking about correlation between symptom and endoscopic finding. Crohn's patients notoriously just don't have symptoms that lined up exactly with how it looked like on the inside. So many of these patients present to a gastroenterologist with stricture, fibrosis that have been there for years. And so referring them to a surgeon is not a failure, but you can help them relieve symptom and improve their quality of life. I tell the patients it's almost like you need a fresh start. You need a reset. Let's get that scar segment out. Let's get that disease segment out and have a fresh start. Colectomy is a cure for UC, as you know. And sometimes, for certain patients who have high risk of post-op recurrence, we put them on biologic therapy, and that worked really well to prevent another course needing surgery. Many of these strictures are mostly mixed with inflammation and fibrosis. And like I said, fibrosis are not reversible, not completely. So this was a study looking at radiologic findings that will help us determine their need for surgery. So SSS score is a development SSS score looking at internal fistula, small bowel obstruction, proximal dilatation of 3 centimeters or more, abdominal mass, abdominal abscess, mesenteric stranding. These are all risk factors for high-risk radiological strictures, so to speak, radiological findings. And if your radiological findings are concerning, meaning you have any of these features with a score from 1 to 5, you can see that the red line here indicating biologic use, the blue line indicating no biologic. We are not making a significant difference in our patient's disease course. Many of these patients will end up needing surgery. However, if you don't have any of these features, it's possible that biologic therapy may reduce the risk of surgery. The PREVENT trial was a trial looking at, okay, you have resetted the system, you've taken out the disease segment, what are we going to do next to prevent these patients from getting recurrence of disease? It was very clear that prior to this trial, patients who went on no post-op therapy had at least microscopic recurrence by 1 month after they've had their surgery. And by 6 to 12 months, we are able to see disease recurrence on colonoscopy. So Miguel Reguero conducted this study looking at randomizing patients to either receiving infliximab post-op or placebo post-op. And it was clear that clinical recurrence was not significantly different. And the way I seem to interpret this is, again, patients' symptoms don't always correlate with endoscopic feature. And after a bowel resection surgery, many of these patients can have other concurrent diseases or condition that is not related to active Crohn's disease. For example, you can have bile acid diarrhea after an ileocecal resection. You can have small intestinal bacterial growth after a bowel ileocecal resection. What's notable is that when you look at their colon at week 76, it was clear that the group who received placebo had a much higher rates of endoscopic recurrence. And this is the objective way to show that infliximab post-op did make a difference in preventing disease. So in the past decades, we've started moving, in the past 5 years or so, 5 to 10 years, we've started moving beyond just azathioprine and anti-TNF therapy. And the reason is we have identified novel mechanisms to target. This is a very busy slide, but bear with me. This is to indicate your lymphocyte. And traditionally, our anti-TNF class, the infliximab, adalimumab, golimumab, sertolizumab, they are TNF alpha receptor antagonists. So you're working on the TNF receptor. The next generation of biologic, the vedolizumab over here, it's an anti-integrin agent. And what it does is, imagine this being your blood vessel, and then this is your bowel wall. The vedolizumab anti-integrin agent is basically working to block the lymphocyte from entering your bowel wall therefore not producing the inflammation that we see in inflammatory bowel disease. And since vedolizumab, we have had ustekinumab, which is an anti-IL-12/23 agent, again, targeting the lymphocyte. We have had the Janus kinase inhibitor, the tofacitinib for ulcerative colitis. We have had filgotinib for Crohn's disease. And most recently, we have ozanimod. And ozanimod is a S1P receptor target agent where it's preventing this is the lymphatic system. This is indicating a lymph node, if you will. So ozanimod works by inhibiting the lymphocyte from going into the peripheral bloodstream. So we have, been targeting different areas of this inflammatory pathway to help address the inflammation we see in inflammatory bowel disease. So we're going to switch gear a little bit. Before we talk about vedolizumab and ustekinumab, the newer agents, I want to talk about the biosimilars for a little bit because patients will bring that up in your practice. So what are biosimilars? So the FDA has approved biosimilars as long as these biochemicals are no different, these biochemicals do not have meaningful clinical differences in efficacy or safety. When Janssen lost their patent to Remicade, now different companies, including Pfizer, have been able to use that formula to generate biosimilars to drive down costs. When there's competition, there's decrease in costs. And it's estimated that with biosimilars in the picture, the U.S. healthcare dollars will have at least $50 billion of saving in 10 years with the introduction of biosimilar. The North Switch trial was a trial looking at patients who were doing well on Remicade that got switched to a biosimilar molecule, the CTP13. And what they saw was very similar efficacy, similar safety profile across all of these indications that Remicade was approved for. And many of these patients, they then did a trial looking at, okay, so switching is okay. What about new start? So looking at infliximab biosimilar and new start for patients with moderate to severe Crohn's disease and patients with versus those who got the originator infliximab. And what they saw was similar clinical remission rate at week 6, week 14, and week 30. For their maintenance part of the trial, they looked at, okay, so you can give biosimilar to induce the patient into remission. What about keeping them in remission on biosimilar? So here are the 4 groups. So biosimilar induction, biosimilar maintenance, and then biosimilar and originator for maintenance. The green highlights the group that received originator product for induction and maintenance. And then the purple indicates originator followed by biosimilar. As you can see, these patients all did very similarly in rates of clinical remission. So Gemini trial looking at vedolizumab in UC, there was an appreciable difference in clinical response, clinical remission, as well as mucosal healing. Again, clinical response, clinical remission, all are based on symptoms. And nowadays, any of these drug trials, it's not good enough that the patients feel better. We want to see actual mucosal healing. And this is to show that they were able to demonstrate durable clinical response and at both dose dosing at both every 8-week and every 4-week. Currently, the manufacturer recommendation is every 8 weeks. As you can see, there's no appreciable difference, but compared to the placebo arm, both dosing did better. So up till this point, we have had these drugs that kept popping up, and it was unclear, how do you choose which is better? A common question that we get in practice, patients want to know which one is better. Well, the Varsity trial was the first head-to-head trial we have in IBD. We're looking at adalimumab versus vedolizumab, again, an anti-TNF agent versus an anti-integrin agent in our UC patients. And dose escalation was not allowed in this trial. So at the manufacturer dosing, it was shown that vedolizumab had a higher rate of inducing clinical remission, endoscopic improvement, and patients that have like cortical-free clinical remission was not superior in the vedolizumab group. What about ustekinumab? This is our anti-IL-12/23 agent. Looking at the left side first, we are looking at the clinical response in patients who had either placebo or the dosing of 130 milligram or 6 milligram per kilogram, so weight-based. And what they found was similar response in both dosing, but appreciably higher than the placebo. And what's interesting and important to note is that patients who are anti-TNF naive did much better than those who have failed anti-TNF therapy in the past. And this will become a common theme with the newer drugs. What we're seeing is that if you use these newer agents as a first-line agent, patients tend to respond much better than if you try anti-TNF first and then hop onto the, whether that's because there's some switch in the immune system after anti-TNF exposure, or whether they just have more aggressive disease to begin with, it's still not clear. Now, looking at clinical remission at 8 weeks, so not just response, but actually in remission, we are seeing that the treatment arms did better than the placebo arm, as you can see. Now, the ustekinumab maintenance trial in Crohn's disease also showed that not only are you able to get patients to feel better, but maintaining them on ustekinumab actually did have a difference in clinical remission and steroid-free remission here. The second head-to-head trial, the CView, was looking at ustekinumab versus adalimumab for induction and maintenance. And it was clear that at this trial, with over 380 patients randomized 1-to-1 to ustekinumab or adalimumab, they found no difference in clinical remission at week 52. And the adverse reactions or events were similar to what each drug had reported previously. So really quickly on tofacitinib, this is an oral agent. It's the kinase inhibitor, the JAK inhibitor agent, looking at its efficacy in UC patients. What we saw was at this dosing, 10 milligram twice a day, there was an appreciable difference. Again, patients who are TNF naive always did better than those who had TNF exposure before. And the remission was sustained, mucosal healing was sustained at 52 weeks. So ozanimod is our latest drug, and this was tested in patients who have had prior TNF exposure. The blue indicate your ozanimod group. Remember, this is the S1P receptor antagonist, limiting amount of lymphocyte into the peripheral blood, being used for UC. And again, they did not show a significant difference in endoscopic improvement, but clinical response was noted in the prior anti-TNF group. In the ones who had no prior anti-TNF, they definitely did better, showing endoscopic improvement. So this drug is best used if someone has never had an anti-TNF exposure before. So it's clear that even by week 52, endoscopic healing was noticeable in both groups here. Just quickly on our perianal Crohn's disease population, we have started doing trials using mesenchymal stem cell. The Meyer UC study, the Meyer CD study was looking at patients who had complex perianal fistula who have failed medical therapy. And what happens is they come in, the surgeon would clean out the fistula, and in a few weeks they come back and the surgeon will inject either stem cell or placebo. 6 months later, these patients get an MRI to look for remission, meaning closure of these openings, no evidence of abscess greater than 2 centimeters. And it was noticeable that the stem cell group had an increased rate of combined remission when compared to the placebo arm. So we're hopeful that stem cell will become widely available in the future for some of these patients who are struggling with perianal fistulas. So I wanted to quickly wrap up by talking about the integrated care model. You know, even though our IBD patients only encompass about 14% of all chronic diseases, the expenditure is huge, and it's based on the cost of these biologics. So biosimilar is going to change that field. In addition to that, the biopsychosocial model of the disease. Every patient has different needs. Some patients will have more social needs, psychological needs, or bio needs. So it's very important to tailor our care to their individual needs. Medical home model, having a collaborative care, interdisciplinary care, having scheduler, dietitian, gastroenterologist, psychiatrist, social worker are all very, very important, as well as colorectal surgeon. It's clear that medical homes reduce ED visit and hospitalization. When these patients have a multidisciplinary care, we see that they're showing up to the ER less, they're being hospitalized less. So, you know, I think we all can agree that over the pandemic, we have transitioned a lot of our outpatient visits to telehealth, but it's also clear that we were able to still start patients on biologic therapy, still have them come in for clinical trials, and still maintain care of multidisciplinary team. And one thing I just want to highlight, I think this telecare success rates and predictors of failed telehealth, this study demonstrated that if patients are older, they found that actually Medicare and Medicaid patients had a harder time getting telecare visit. And of course, they saw an odds ratio of greater than 2 in our African American patients. So these are the high risk patients we want to be mindful of when we are thinking about telehealth. I apologize for going over a little bit. I wanted to open it up to questions and wanted to acknowledge that a thank you to my mentor, Ray Cross, for sharing some of his slides with me for this talk.
Very good. Thank you, Dr. Wong, for that comprehensive presentation on advances in inflammatory bowel disease. I agree. Inflammatory bowel disease care has changed dramatically in the past decade, really, but we still have a pretty long way to go. One of the things that you talked about was this fact that we're having this incremental improvement in care with newer agents that come on board. We have yet to break that glass ceiling in inflammatory bowel disease and get that cure that you spoke about earlier. Do you have any insight into how we might be able to, dramatically increase these improvement rates in patients with undergoing treatment?
Yeah, I think just as we have shown in many studies, inflammatory bowel disease occurs because of one, a genetic predisposition, immunologic factor, an environmental factor, and also a diet factor, which ties in with the environment our gut is exposed to. So many of the studies have been looking at these factors in isolated fashion. They're looking at diet study, they're looking at drug study, immunomodulating study, and it's hard to, and then, there's a genetic component. It's hard to cure a disease that originate from so many roots of origin if you don't tackle them in a combined fashion. But it's also very hard to control a human diet, environment, unlike an animal model. So it's challenging for sure, but I hope that in the future, some of these studies will combine not only diet, but also their antibiotic usage and their immunologic agents, so that we're not just focusing on one little piece of the puzzles.
So it sounds like you feel, as I do, that a multifaceted approach to treating inflammatory bowel disease is probably going to be the way forward in the future. Perfect. Are there any other questions out there?
There's one in the chat.
Go ahead, Dr. Kruger.
That looks, Dr. Dadlani, one of our residents, wanted to know how soon after should you follow up for the calprotectin and the CRP, colonoscopy, et cetera, to assess medication effect?
That's a great question. So because CRP and fecal calprotectin are not so invasive, I tend to recommend checking them 3 months after therapy. And it's not until about 6 months after therapy do we start seeing mucosal healing. So that's around the time I would recommend a patient gets a repeat.
Can I ask one? This is Ashutosh Barve. And my question, Dr. Wong, again, thank you for the wonderful lecture, very stimulating. But one of the questions I had for all of you IBD guys, now that you have so many different mechanisms to attack this disease, I have not heard a lot of talk about combination treatment. How about using 2 mechanisms?
Yeah, so that's a great question. The most inhibiting factor is cost when we talk about 2 treatments. And also, not a lot of studies have been done combining treatment to prove to the patient the safety. But in some of our patients, we do have to do that. For example, if we have a patient who has another autoimmune condition, we may tap into that and have the rheumatologist or dermatologist try to get approval for a second agent to combine with our Crohn's or UC treatment to give them that extra push to the finish line, so to speak, if they're not getting 100% response to just one therapy.
Oh, I see.
I have one other question.
Go ahead.
Go ahead, Jay.
There's one more question in the chat area. Said, what is the effect of regular physical exercise on IBD?
Yeah, I'm so glad someone asked that because the brain-gut pathway, it's been demonstrated, in all kinds of autoimmune diseases. So there's ample amount of literature there showing exercise is beneficial. Stress reduction is beneficial. So we encourage our patients to stay active.
And I have one other question. Fecal calprotectin, I agree, is difficult to obtain for some patients. They may just not be ready to present a stool specimen when they come in, or it may be difficult to get them to follow up. Do you have any experience with transabdominal intestinal ultrasound yet, or is that coming to your center yet?
So we talked about it. We haven't had buy-in from our radiologists, but I know in Europe they've had really good success using that, and I think it's a great modality to have in clinical practice to readily be able to assess inflammation. Are you guys thinking of that?
So I'm actually going to Israel in about a month to go through my first round of training, and I will tell you that I think the VA is going to be an awesome place for us to be able to validate this. Because Europe has the ability to get this paid for, but we don't yet. But I think that the VA is going to be an awesome place for us to be able to bring this modality to the United States, because we won't have the payer, problems that we would have if we were trying to bring this to our academic practice or civilian practice. So let's stay in touch on that topic, okay?
Yeah, I'll have to get training by you after you learn.
Sure. Training is coming to the U.S. here soon, so that's exciting. But right now it's Europe and the rest of the world.
That's super exciting because the problem with Crohn's flares patients when they present to the emergency room, as you know, there's just an excessive amount of radiation from CT,
Yes.
and we've been really trying to teach our residents and the emergency room faculty, please don't CT this person for the 20th time in the 20th month. We have other ways of assessing them, and ultrasound would be fantastic. So I'm looking forward to that too.
I mean, in 5 minutes, you can assess what their response to medical therapy is, and we won't get that blank stare when we say, we need another colonoscopy, and they're like, I have to do the prep again? So, All right.
Are there any other questions for Dr. Wong? Again, we just got a minute. If you can post it in the chat, or if you want to unmute and ask, we got a minute. So,
quick question. It's about you emphasize the importance of having adequate drug level. We do reactive drug monitoring, but some advocate for proactive. Is there any evidence for that? If so, is it easy insurance-wise, to get approval for proactive drug monitoring without any evidence of high CRP, calprotectin, or symptoms?
Yeah, that's a great question. Currently in the GI guidelines, we're encouraged to do reactive monitoring. So when patients come in with symptoms, then we are going to check their drug level. But you're right, proactive monitoring, it's not widely accepted, even amongst GI IBD specialists. There's two boats, like some people are into the reactive monitoring and others are in the proactive. Our center is on the proactive boat, so we check it. At least in the state of Maryland, we haven't had issues. And I'm not saying checking drug level every 3 months if patients are doing well. I check it once a year. If they're doing well, I'm just checking it once a year to make sure that they haven't developed antibody, because if they have, I need to do something different. If their drug level dipped down, I'm going to proactively bump their dose. So again, that's proactively making sure they don't flare, don't end up at the emergency room, but it's not in the GI guidelines to encourage proactive just yet, because it's costly to check these labs.
Although I will say that we typically go through LabCorp, I'm sorry, not LabCorp, Quest. And I ask every patient that I get the therapeutic drug monitoring on whether they've gotten a big bill. And I have not had anybody come back and say that they've had any problems getting this
Yeah, I
paid for.
haven't either. Good.
So back in the old days, when we only had one provider for therapeutic drug monitoring, I think that was a problem. But now that we have other testing modalities, it just the cost has come down pretty dramatically.
Good.
All right,
All
Jason.
right, guys. We're going to say we're pretty much gone over a little bit, but I want to thank Dr. Wong for a great presentation, outstanding presentation. Thank you, Dr. Dryden, for inviting Dr. Wong. And Dr. Wong, just real quick before you go, we have a little tradition at the University of Louisville for our guest speakers that we've continued even through the virtual presentation realm. And so you will be the recipient of something very special to the city of Louisville, your very own Louisville Slugger Bat.
Oh my gosh, that's awesome.
Yeah, so I'll get in touch with you about a shipping address and such. But thank you so much. And Dr. Dryden, if you have anything you want to wrap up with, or
Well, I just think that it's really good to hear young investigators and clinicians coming up through the ranks and being so involved in the education of our residents and medical students. I just wish you great success with your career as you move forward. You obviously are a rising star, so best of luck.
Thank you, everyone. Thank you.
thank
All
you.
right.
Dr. Kruger, did you have any final words?
Yeah,
Or you...
I really liked your presentation style. It's for those of us that aren't immunologists, some of your slides that were very good. That you explained the detail, particularly the different classes of biologics slides. So I think that a lot of this stuck. I also appreciated in the beginning of your talk how you mentioned young people with disease are harder to treat, generally have a worse disease, and I don't know if that's because they have more robust immune system or immune system dysregulation at that point, but also that you mentioned the holistic treatment of these patients. I think there were some concepts that really stuck for us, and we will probably do a better job managing our patients with your talk. So I really appreciate you. Thank you.
Thank you.
All right, thank you, everybody.